So in the last segment, I wanted to really talk about some of the potential long-term risks of PPI use that we know of in the pediatric literature so that you can help keep your patients' families and the patients themselves up to date. And I also wanted to ask the question of how can we limit long-term use of the medication in situations where it was appropriately prescribed in the first place. So let's now go back to that case of that 4-month-old girl whose parents are worried about gastroesophageal reflux disease. So let's say that you educate and reassure her parents that the potential for reflux to decrease over time is worth waiting before starting a medication, and also the fact that this may not be reflux disease at all, and symptoms gradually go away with time. However, now she comes back and she's 4 years old, and she's presented with the most common presenting features of esophagitis for her age, which include her food refusal and regurgitation and vomiting. And this occurs following an episode of gastroenteritis. So you make an appropriate referral to the gastroenterologist, who does decide on an endoscopy, not necessarily to look specifically for erosive esophagitis, but also to look for other etiologies such as eosinophilic esophagitis, which may present similarly. And so he or she sees this in the lower esophagus. You can see there a mucosal break in the lower esophagus at around the 11 to 12 o'clock position, which can be seen often in reflux esophagitis. And so, concerning enough, it is recommended that the patient start on a PPI. However, the gastroenterologist was in a bit of a rush that day, and the parents have heard some things in the media as of late, and they approach you. So now let's talk about some of the side effects for the potential risks of long-term PPI use. A lot has been made in the literature and in the media about PPI risks, and there are clearly some concerns that we need to be aware of as prescribers. However, I wanted to mention before we go through all of these potential concerns and we get too deep that these are generally very safe medications. In one recent review of the literature going back over the last 10 years of randomized controlled trials involving PPI use in pediatrics, Shlomi Cohen and co-investigators in 2015 showed that adverse effects were very common, up to 34% in some cases, but often quite mild. So to help remember the PPI side effect profile, it's best to think about 3 different categories or mechanisms. The first group would be considered side effects that are thought to be directly related to the paucity of hydrochloric acid production by the stomach, which is the intended consequence and a direct result of proton pump inhibition. The first thought would be that you'd be at higher risk of infection because the acid has a protective mechanism to prevent bacteria that we ingest or swallow from the upper airway and to keep these bacteria in check. And this also may be related to other effects on the immune system. For example, PPI use has been associated with anti-inflammatory properties as well as with effects on the migration of white blood cells. And there's also been some work that have shown that there may be increased leakiness or permeability of the epithelial mucosa. So this might explain why PPIs as a group tend to be associated with higher rates of infection when compared to H2 receptor antagonists. And there absolutely is a concern that their use in patients who are immunosuppressed or immune compromised or who have indwelling central catheters can put these patients at risks for serious infections. But what I was surprised to read about lately is the literature that have actually shown associations with other infections in generally healthy infants and children. So one of the ones in particular is Clostridium difficile infection. And in one recent study by Turco et al., the odds ratio was 4.52 for those receiving PPIs. And this was further increased if the patient had received antibiotics, which makes sense. And the thought was that there was likely a lower risk with H2 receptor antagonists based on the data. There have been studies showing an association with certain bacterial enteritis in addition to Clostridium difficile. So, for example, Salmonella. And small intestinal bacterial overgrowth is also a distinct possibility. There was one recent interesting study in 2015 in Pediatrics where patients who were started on a PPI developed abdominal pain, and several had other symptoms such as bloating, flatulence, eructation, all of which led to testing for small intestinal bacterial overgrowth. And this was tested in these patients and others who were receiving PPIs without symptoms. And those 4 symptoms were positively associated with a positive diagnosis of bacterial overgrowth in a significant proportion. Necrotizing enterocolitis and sepsis, a lot of the data comes obviously in these cases from the NICU. And finally, lower respiratory tract infections such as ventilator-associated pneumonia in the PICU, but also studies in the community showing increased lower respiratory tract infections and community-acquired pneumonia. And the theory here is that the bacteria found in gastric contents in patients on PPIs do tend to have organisms that are associated with lower respiratory tract infections. And so the thought there is that these bacteria, which may be in larger quantities in the stomach, then are more likely to be aspirated. So that highlights some of the infections. But the other part was for this risk. It's certainly plausible because there are several nutrients whose optimal rates of absorption are achieved when they're an optimal pH, either because the low acidity of the stomach is needed to help break up some of the protein-bound components, protein-bound nutrients, such as vitamin B12, or that the stability of a nutrient, such as iron, is best achieved in an acidic environment. So for example, iron is more in its more soluble form when exposed to acid. And the thought is also that calcium may be more soluble in an acidic environment. In some adult studies, patients who have been on PPIs for a long period of time have shown a slight decrease that has been, I believe, statistically significant, but not clinically significant in terms of hemoglobin and hematocrit. There was also a study that showed that patients who had hereditary hemochromatosis who were on a proton pump inhibitor did not need to have a phlebotomy as readily to keep their iron levels in check. B12 studies, in my opinion, have been fraught with some difficulties, primarily being that B12 levels alone have been used rather than other more sensitive indicators such as looking at the methylmalonic acid and the homocysteine levels, which are often elevated prior to the development of a true overt B12 deficiency by blood work. So based on all of these studies looking at the nutrients, there really isn't enough evidence to suggest, in my opinion, that patients who are on long-term PPIs need to be routinely screened for these deficiencies unless there is a reason to suspect it based on clinical symptoms or the patient has already other predisposing risk factors for the development of these deficiencies. So the second class of side effects are actually related to, again, expected consequences of PPI use, and that would be the subsequent hypergastrinemia that develops in response to the inability to secrete acid. And a particular effect seen after long-term high gastrin levels is the effects that can happen on other cells. So in fundus in particular, you can see the development of fundic gland polyps as a result of stimulation with hypergastrinemia, usually over a long period, and has not been seen in less than 12 months of use. There are several case reports suggesting reversibility of the polyps after discontinuation of the medication, and in one recent review, only 1 out of 107 patients with fundic gland polyps associated with PPI use had any dysplasia. There is no evidence that high gastrin induces neoplasia of any kind, particularly in the fundus, which has been the biggest concern. In addition to its effects on the parietal cell, which is its main effect with respect to hypoplasia and hypertrophy, it can also have effects on the ECL cells, or the endocrine cells in the GI tract. And in rats, gastric carcinoid was reported with use of PPIs, but this has never been reported in humans. In other epithelial cells, gastrin can also have effects, but again, not associated with colorectal cancer in various long-term studies for up to 15 years in both the UK and Netherlands. And lastly, there have been some suggestion that the hypertrophy and hyperplasia of the parietal cell can occur at the expense of other cells within the stomach, and there have been reports of atrophic gastritis, in particular in association with H. pylori, because sometimes this can be a precursor to gastric cancer. There have been suggestions that patients who have concurrent H. pylori should be treated for eradication prior to the consideration of long-term use of PPIs. However, this may be more of a concern in patients who actually have a strong family history of gastric cancer. All this to say that the risk of long-term changes in the stomach being of a concerning nature is probably not the case, and these effects are probably, again, a natural consequence of the use of the medication. Now, the other effect of gastrin, which does come into play for the vast majority of patients who have been on it for a long time, is the fact that the high gastrin can take some time to decrease, and when you remove the PPI suddenly, you'll have rebound hyperacid secretion, which can exacerbate symptoms. And then finally, we have the grab bag, the list of a variety of different potential reactions that can occur with PPIs, most of which are idiosyncratic and actually make up the largest component of all adverse effects experienced with PPIs. So the overall risk of an adverse event, like I had mentioned, it can be up to 34% of pediatric patients on long-term PPIs. However, the most common side effects reported were headache, nausea, vomiting, and regurgitation, diarrhea, and abdominal pain, which may or may not, again, be related to the use of the medication itself. Some of these may also resolve with a reduction in dose and or change to another PPI. I will show you a study regarding bone health on PPI in a moment. However, I put it in this category because it is not necessarily related to calcium malabsorption, as was previously thought to be the case. That certainly may play a role. However, there have been some studies suggesting that there is decreased osteoclast resorption of bone in some patients who are on these medications, and the question is actually whether or not the effects may actually be at the level of the bone because of the effects of PPIs on other cells, not just those of the stomach. That would also explain potentially why there could be decreased calcium and or magnesium absorption at the kidney. There are certainly proton pumps in the kidney which consist of isoforms that both resemble and have similarities to those in the stomach. With respect to acute interstitial nephritis, there have been no childhood cases described as of the literature review that I have conducted. The thought, however, is that this could be a significant cause of acute interstitial nephritis in adults, and particularly in the Australasian continent. There have been reports that this may be the most common etiology for this fairly rare but severe condition. This could be related to direct toxicity on the kidneys related to the effects of the medication on pumps, or due to effects during clearance of the drug from the kidneys. And then the thought would be that the toxicity leads to inflammation and the nephritis. I had already alluded to hypomagnesemia or low magnesium levels in the blood on a couple of occasions. However, suffice to say that there really isn't a whole great deal of evidence. There have been some case reports, though, of severe hypomagnesemia in patients on PPIs, and a plausible mechanism as to why that may be related to the medication. And then finally, dementia and cardiac effects have been listed here. I did not review the dementia association that has been borne out in an article in the last year. However, suffice to say that the evidence for this is about as good as that for the cardiac effects, which isn't that good to begin with. So let's quickly go through a couple things, particularly the bone health and the cardiac effects. So with respect to the bone health, this was one of the more recent studies and one of the few looking at pediatric age groups, but they did break it up into pediatrics and adults a priori. And this was a retrospective review. It was a case control study looking at electronic medical records from the THIN database in the UK. And they matched the controls for comparison with cases for some of the features that may be considered confounders for the development of fracture. And these patients were randomly selected following matching. And they a priori picked 6 months of PPI use to be considered an exposure, but they looked at various levels of exposure, as we'll see, of cumulative exposure. And they also adjusted for medication use in order to calculate an adjusted odds ratio for PPI use and fractures. And they also assessed for possible dose response by subdividing groups by the dose frequency or intensity and the cumulative dose exposure. And so what they found was that the adjusted odds ratio for patients in the pediatric age group was such that the 5% confidence interval clearly crossed 1, thus suggesting that there was no statistically significant association between the use of PPIs in this population and fracture. And again, that would refer to at least 180 doses, or the equivalent of 6 months of treatment. However, in the young adult group, there was a statistically significant association after adjusting for the prior use of other medications that could potentially put them at risk for fractures. And not only that, there was a dose-response relationship that appeared to exist with higher odds ratios associated with higher cumulative exposures in the young adult group. So the question is definitely still out there as to whether or not PPI use in children long-term could have potential risks, especially because the teenage years are the years of peak bone mass accrual, and we really don't have enough long-term data, even in these retrospective studies, to look at 30, 40 years down the road in patients who have received PPIs in their childhood. So what about myocardial infarction? This has definitely received a lot of publicity, this article, and I think there have been a lot of important and honest critiques of the techniques and some of the limitations of the study. And what they did in this study was they called it a data mining activity, where they looked at the main outcome of interest being a myocardial infarction or heart attack. They looked at code-based extractions, and they adjusted for age, gender, race, length of observation, and other drug use. And then what they did was similar to the bone health study that I just explained. They tried to match cases and controls, and they found a statistically significant odds ratio showing an association between proton pump inhibitor use and myocardial infarction. As some people have noted, it is quite curious that such an association was not seen with an H2 receptor antagonist. Actually, the use there almost favored a reduction in MMI, the confidence interval almost, but just barely crossing the line of 1. And also, what seems to be odd is that some PPIs were clearly associated with the outcome of MI and others were not. So the odds ratio is 1.16. And when you do the calculations, it actually works out to the number needed to harm of 4,000. So 4,000 patients would need to be treated with PPIs to induce one additional MI based on the association data. That, of course, would presume that the effect seen here was purely due to PPI and it was causal, which again an association study cannot prove. What in particular people have keyed in on is that they did not report on other known risk factors for myocardial infarction in either group, which may actually skew the data because, for example, patients who are more likely to be on PPI in adulthood may be more likely to be obese and thus have a higher risk of myocardial infarction at baseline. But there have been some theories as to why PPI in particular may be associated with myocardial infarction, and those include the effects of PPIs on endothelial nitric oxide release, and also a question of whether or not it has effects on clopidogrel action, clopidogrel being an antiplatelet agent. So in summary, we've talked about some of the main risk factors that have been reviewed in the literature in pediatrics and adults, and have touched on some of the more recent articles. The risks, whether proven or not, are plausibly broken down into 3 different groups. One's related to the reduction in chloride production by the stomach. There are several associations with infections based on the literature, and this may also be a predisposition on the basis of the effects of PPI on the immune system. Reduction in acid production can also plausibly reduce the absorption of nutrients, and I've listed some of the ones that have come under scrutiny here. However, none have been proven in large-scale studies, and the question of whether or not they're actually clinically significant remains in question. But again, these should be considered in patients who have already predispositions to the reduction in the absorption of these nutrients. As a consequence of the reduced chloride production and hydrogen production by the stomach, gastrin levels will increase in the blood as a normal expected consequence. These do likely explain the morphological changes noted in the stomach and possibly in other parts of the gastrointestinal tract, but are likely to be clinically insignificant and have never been proven to increase the risk of malignancy, although there's a theoretical risk in patients who have atrophic gastritis induced by H. pylori in adults. Of note, and we'll talk about this in the last part, it can lead to rebound gastric acid hypersecretion when the medication is abruptly discontinued. Finally, we have the last group known as the idiosyncratic reactions, which can be broken down further into the common and mild side effects, which commonly occur with any medication, and in the case of proton pump inhibitors, usually do not lead to discontinuation of the medication. And then the second group, which consists of a grab bag of side effects which have not truly been proven in adulthood, let alone in pediatrics, although the one to take note of is bone health, and this does remain a significant concern that is worth discussing with parents of prospective patients to be on these medications, and may also pertain to other factors beyond the reduction in calcium and magnesium absorption that has been suspected, and it actually may be related to direct effects of the proton pump inhibitors on the bone itself.